So thank you everyone for joining. Great pleasure to have Richard Polin. He's a hero to many people, and Richard Martin hanging on to watch the show. So Dr. Polin, thank you so much for talking to us. You've got a worldwide audience. India, Indonesia, Malaysia, down in Randwick. And he will be speaking to us on healthcare infections in the NICU, lessons for everyone. Dr. Polin, what we'll do is we'll mute everyone on entry, and then at the end, if you have time, we'll invite questions through the chat pane. But if anyone's really desperate, just put the hand icon up, and hopefully you can break the talk to address their questions. This talk will be recorded. With your permission, I'll send it to you first to have a look to see whether there's anything dodgy in there. But after that, it'll be posted on our school website, and I'll post the website on the chat pane. So without further ado, over to you, Dr. Polin. Thank you.
All right. Thanks, Julie. It's great fun for me to be speaking to Southeast Asia and Australia. I wish I could be there in person, but the times will not allow this. So I'm going to be speaking about one of my favorite topics, which are healthcare-associated infections, used to be called nosocomial infections. And it's my favorite topic because it starts, let me advancing my slide. There we go. With a little history. And this is a picture of Ignaz Semmelweis, who's one of my heroes in medicine. And for anybody who works in a NICU, this should be one of your heroes too. We lived in the 1800s, and he was not a pediatrician, but he was an obstetrician. And in about 1830, he went to work in the largest maternity hospital in Vienna. And when he got there, which is shown about where this red arrow is, he was astounded by the maternal mortality rate in comparison with another major city in Europe, and that was Dublin. So Dublin's shown in the black line, the mortality rate in his hospital is shown in the green line. And just to orient you, when the rate of maternal mortality went up in Vienna was this point here, and that was the time they started the Department of Anatomical Pathology. I'll tell you why that is important in just a moment. At this point here, though, Semmelweis made two observations. The first observation happened because they separated the nurses, midwives, and MDs who took care of women in labor. And when they did that, the mortality rate in the group of women delivering by midwives went down substantially, but the rate among women being delivered by physicians went up. The second observation was happened to a friend of his who cut himself while doing an autopsy. And when that physician died, his autopsy findings were almost identical to the women who had died in childbirth. And this is what the autopsy room looked like back in the 1830s. Everybody was crowded around a woman who had died in childbirth. But if you look, nobody's wearing gloves. So they went from the autopsy room up to the labor and delivery room where women were having children and did pelvic examinations without cleaning their hand. So what Semmelweis did, he thought, well, there has to be something about the women who have died and transmitting it to the women who were in active labor. Semmelweis made everybody soak their hands in a chlorinated lime solution. This is obviously not a photograph, but a recreation of that. And that, we know, historically killed the germs on the doctor's hands. And this is actually from Semmelweis's journal, where the risk of women dying in childbirth went all the way down. So Semmelweis wrote a classic monograph, which roughly reads, I don't speak German, on the etiology and understanding and prevention of childbed fever. Childbed fever was this disease that was occurring in women who died during childbirth. And that was rebuffed in the international community. In fact, Semmelweis had to leave Vienna. He moved to Budapest, As you know, they eventually have named a whole university after Semmelweis University. But to finish the story, the tragic part of the story is that Semmelweis died at a very young age in his early 1940s, and he died in an asylum because they thought he was crazy, where they used to beat people, and he died from infection. So here's my outline for this morning. I'm going to talk about the risk factors for healthcare associated infection and how to avoid those care practices in the NICU. Part of my talk is on central line associated bloodstream infections, which are known as CLABSIs, CLABSI. Then I'm going to talk about a difficult diagnosis for me, that's ventilator associated pneumonia, and end by talking about predictive monitoring. So healthcare associated infections are costly. These are not recent data, but estimates from about 5 to 8 years ago said that in adults and children, healthcare associated infections cause 100,000 deaths and have an actual a dollar cost of about $6.5 billion. These are probably underestimations, and I would guess that we're in the tens of billions of dollars now in the US. The Center for Medicaid and Medicare and Medicaid Services, which determines how hospitals get reimbursed, do not reimburse a hospital where someone has developed a catheter associated bloodstream infection. They call those never events, sort of like falling out of bed. These infections are responsible for about half of all deaths after 2 weeks of life. They're associated with poor neurodevelopmental outcomes. And unfortunately, they are common events in the NICU. This is looking at two databases for the rates of central line associated bacteremia. In parentheses is the data from INIC. Now, many of the people listening to this audio cast, this webcast, know that INIC is the International Nosocomial Infection Control Consortium. And as you look at those data, they're broken down to different birth weight categories. The numbers go from 4, but they go up and down, do not change very much. Whereas you look at the comparable US data, obviously the risk of central line associated bacteremia per 1,000 catheter days is higher in tinier babies, but then goes down. So you have to ask yourself, why didn't these numbers go down like they did in the US? And I think, but can't prove it, that hand hygiene is a major part of that. This is the best study that I know of looking at the economic costs of nosocomial infections or healthcare associated infections. In the figure here, the cost of hospitalization of babies with infection is shown in yellow. The cost of hospitalization of babies without infection is shown in blue. And on the x-axis are different birth weight categories. Now you see there's two sets of bars at every birth weight category for observed data and then adjusted for confounding variables. But in every birth weight category, the cost of hospitalization is greater in babies who have a hospital-acquired infection or healthcare-associated infection compared to those with no infection. The actual differences in cost are shown in the upper right-hand corner of the slide, broken down to different birth weight categories, but the difference is for babies with no bloodstream infection versus a bloodstream infection is about $30,000 in each birth weight category. And as you might imagine, the costs of hospitalization vary with the pathogen causing the infection. So in babies without infection, the mean cost of hospitalization in this study were about $50,000. Coagulase negative staphylococcus, which is a common cause of infection, the cost of hospitalization doubled and went up with other bacteria, which means Staphylococcus aureus and gram negatives, even higher. And the highest cost of hospitalization went up with fungi. This is one of several studies looking at the neurodevelopmental outcomes of ELBW babies who have had a documented infection. These are data from the Neonatal Research Network published by Barbara Stoll, looking at 18-month follow-up. And the 4 outcome variables they looked at were MDI, or Mental Developmental Index, PDI, or Psychomotor Developmental Index. CP is obviously cerebral palsy or microcephaly. And everything on the slide shown in blue is statistically significant. That infection worsened the MDI, PDI, and caused an increase in cerebral palsy and microcephaly. And there have been other studies to substantiate that. Let's talk a little bit about the epidemiology of CLABSIs, these central line associated bloodstream infections. So I put 5 studies on this slide, and except for one of them at the very end, they identify as coagulase negative staphylococcus, responsible for about 50% or more of these kinds of infections. The last study I'll show you in detail in a second is from Yale, in which they showed a marked decrease in infections due to coagulase negative staphylococcus. Beyond coagulase negative staphylococci, Staph aureus and gram negatives are the most common, followed by enterococcus or group B streptococcus, and then fungi. But let's take a look at the Yale data. The Yale data is broken down to 3 time periods, 89 through 2003, 2004 to 2009, and 2010 to 2013. And you can see for several years, it was either the most common or equal to the most common cause of CLABSIs, central line associated bloodstream infections. But then in this epoch, 2010 to 2013, something happened that made it all different. In fact, gram-negative enterics became the most common cause of these central line associated bloodstream infections. And that's shown graphically over here, where the rate of late onset sepsis went down, but an increased predominance of gram-negatives. And what happened at this point were 2 things. First is they instituted a bundle, and we'll talk about bundles of interventions to prevent these kinds of infections. But they also changed how they defined an infection due to coagulase negative staphylococcus. In the past, they used to do central line blood cultures, but they stopped that and defined a infection due to coagulase negative staphylococcus as 2 positive peripheral vein blood cultures. So this is how I would interpret positive blood cultures for coagulase negative staphylococci. In a symptomatic baby, I would draw 2 peripheral blood cultures. Obviously, if you're concerned about sepsis, you start broad spectrum antibiotics. I'll tell you what I would start in just a few moments. If both blood cultures are positive for coagulase negative staphylococci, if both blood cultures are negative, is obviously not sepsis. If both blood cultures are positive, we call that coagulase negative staphylococcal bacteremia. If only one culture is positive, we interpret that as presumed contamination, but we do not take blood cultures from the central line anymore. These are the risk factors from a lot of studies looking at what predisposes to these central line associated bloodstream infections in babies less than 1,500 grams. So as you might imagine, the strongest correlation with birth weight and gestational age, parental alimentation, and central lines, obviously key. Intralipid is probably a separate risk factor independent of central alimentation. Steroids for BPD, histamine blockers and protein pump inhibitors, low serum immunoglobulins. We know this from research studies, but it's not generally drawn clinically. Prolonged duration of mechanical ventilation, which identifies a sicker population, overcrowding, heavy workloads, and some people like to blame nurses, but I think that is probably not appropriate. This is a survey study published in Lancet several years ago, looking at about 85 centers in the UK, and they looked at centers for 3 variables: patient volume, number of consultants that were available, and nursing provision. And on the y-axis is the incidence or percentage of babies with nosocomial bacteremia. So in centers with a high patient volume, where they obviously care for sicker babies, there was a higher risk of these infections. Nurses didn't make a difference at all, even though there were more nurses in the larger NICUs. But the number of consultants did make a difference. In the NICUs with a lot of consultants, there were more infections as compared to NICUs with lower numbers of consultants. And he asked me, why is that? And the answer is, doctors don't wash their hands. So how do we prevent these central line associated infections? First of all, we have to have a case definition for what we call a CLABSI. This is what the CDC uses. There has to be a recognized pathogen, like Staphylococcus aureus or E. coli, and at least one or more blood cultures not related to infection at another site. So if you have an infection, you're in like necrotizing enterocolitis, that's not epilepsy. The second definition is you can have a common skin contaminant like coagulase negative staphylococci in two or more cultures not related to infection at another site. Again, for me, the two or more cultures are two peripheral vein blood cultures, but the baby also has to be symptomatic. It has to be fever, hypothermia, apnea, bradycardia, or hypotension, any of the signs that we associate with sepsis. So this is what the World Health Organization recommends for hand hygiene. This is what we practice in our NICU and the NICUs around the US. It talks about what are the opportunities for good hand hygiene. And some of them are obvious, like before touching the patient, before doing an aseptic procedure, after touching the patient, after a body fluid exposure. But number 5, I think, is ignored many times. If you come to our hospital in New York, which I hope you get to do, and you make rounds with me, they take about 2 hours at the bedside. And invariably, one of the house staff begins to lean on the counter or touch the isolate. And if you do that, you're increasing the risk of transmission of bacteria from the infant's environment to their skin. And when I see that, I ask that house staff person to use hand hygiene at that point. Why does hand hygiene work? Because it removes the superficial flora. Remember, there are two kinds of bacterial flora, one which is called transient, the other is called resident. The resident bacteria, as illustrated by these little bacteria in a pup tent over here, live deeply in the skin. And what you do for hand hygiene probably doesn't affect those bacteria. Where the superficial bacteria are the ones that cause nosocomial infections in babies. And hand hygiene techniques, especially those that degerm hands, are very effective in eradicating these transient bacteria. So here are some official recommendations by the CDC for hand hygiene. Use an alcohol-based hand rub routinely when you want to decontaminate your hands. But if your hands are dirty or contaminated with blood or other body fluids, wash the hands with either a non-antimicrobial soap and water, which I think is preferable, or an antimicrobial soap and water. But I prefer to use non-antimicrobial soap and water because these substances, like chlorhexidine soap and water, cause injury to the skin. Soaps and detergents, those that are anionic or cationic, like chlorhexidine, cause the most damage to the skin. And remember, damaged skin harbors the most pathogens. Brushers are no longer recommended. Surgeons still use them, but again, brushes cause injury to the skin and allows you to harbor more bacteria. Do not use artificial nails or extenders. When I first came to Columbia, we had an outbreak in my NICU of Pseudomonas bacteremia over an 18-month period. And after a long period of investigation, we traced it to a nurse that was using artificial nails with nail polish, and she was colonized with Pseudomonas. And when the nails were cut and cleaned, the Pseudomonas epidemic in our NICU stopped. And a very important recommendation is keep your natural hair short. We don't allow dark nail polishes because of the history of the nurses. Clear nail polish is acceptable. Wear gloves when it's reasonably anticipated that contact with blood or an infectious material or mucous membranes or non-intact skin will occur. Hand washing materials and facilities must be available at the point of care. These are strong recommendations. Remember, recommendations go 1, 2, and 3. 1A recommendations are the strongest. 1C recommendation a little less strong. But this is a 1A recommendation. Monitor healthcare workers' hygiene practices. And just like many of you, we have secret observers in our NICU. Most of them are medical students who want to earn extra money. And they come up every morning to watch what the physicians and nurses are doing. And they have a little iPad or a little device where they record every interaction of a doctor and a nurse with the baby to make sure they follow good hand hygiene procedures. And if they don't, then that information comes back to me as a deviation, and I get to talk to that individual. So what is Columbia bundle? Remember, a bundle is a group of interventions. What do we use to prevent these central line infections? Well, this is our insertion bundle when we're putting in a central line. Hand hygiene, very important. Use of sterile gloves, obviously. We use a sterile barrier when we insert a central line. We use chloropep for skin antisepsis. With everything except for UA, UV lines for central line insertion, we use this combination of chlorhexidine plus an alcohol. The trade name is chloropep, but I'm sure similar substances are available in many of your countries. I'm not sure this is important. Optimal catheter site selection. Most of our catheters go into the upper extremity, but the femoral vein has proved okay. And this is important. Daily review of line necessity with prompt removal if necessary. So every day on rounds, we ask ourselves, is this central line necessary for this baby, or have we advanced enteral feedings enough so that the central line can then be removed? When you access the line, we also have a bundle. Obviously includes hand hygiene before and after accessing the line, always maintaining aseptic techniques. We date our tubing because sometimes the tubing going into the central line has to be changed. And we scrub the hub with chlorhexidine or alcohol for 15 seconds. Why do we do that? Because most central line infections in babies are due to bacteria on the inter aspects of the catheter, which then contaminate the vein. They don't crawl along the outside, so scrubbing the hub with chlorhexidine or alcohol gets rid of bacterial contamination and has been shown to prevent these kinds of infections. Do they work? Well, I'm going to show you data through 2012 looking at our CLABSI rates, and they went down and they've remained down. And most months in our NICU, despite one of the highest case mix indexes in the United States, we have no or occasionally one central line associated bloodstream infection. So the bundle has been very effective for us. So how do you manage a central line infection? The best thing is to take out the central line if possible. It's mandatory for fungemia like Candida, strongly recommended for Staphylococcus aureus, but for other pathogens, if you need the central line, you can keep it in, but only if it's vital to the infant's well-being. The one exception may be an infection due to coagulase negative Staphylococcus, where we generally treat with the central line in place. Remember, a positive blood culture for coagulase negative Staphylococcus through a central line and a negative culture from a peripheral vein represents line colonization, and that is not a central line associated bloodstream infection. When eclampsia is suspected, we have a choice, in the US at least. Some centers use vancomycin and gentamicin, but we prefer oxacillin and gentamicin. We abandoned vancomycin about 6 months ago. If the infection is due to a oxacillin-resistant bacteria, we then switch to vancomycin. We think this is preferable because it avoids using vancomycin in some babies. Once a pathogen is identified and its sensitivities are known, then we narrow the antibiotic coverage. CLABSIs due to coagulase negative Staphylococcus are treated for 7 days. Those due to Staphylococcus aureus for 2 weeks, and gram-negative bacteria 7 to 10 days. And we do a lumbar puncture for any positive blood culture other than coagulase negative staphylococci. Here's my conclusions about this part of the talk. Avoid care practices which bypass normal skin barrier defense mechanisms. If you don't need a central line in a baby, don't insert one. Try to use peripheral vein alimentation. Try not to use UA or UV catheters, or get them out quickly, and try not to do heel sticks. Limit the use of drugs which are associated with these infections, such as steroids for BPD, and histamine blockers or proton pump inhibitors. If you have a baby that's colonized with a resistant or very invasive microorganism, always isolate that baby if possible and use gloves and gowns. And limit the use of antibiotics, and when needed, use the simplest and most appropriate antibiotic. And that's obviously recommendation for antibiotic stewardship. Use alcohol-based emollients. I think that does improve compliance. Do not scrub your skin with brushes because it causes skin damage. Breastfeeding is obviously important. minimize central venous catheter days, and use sterile barriers for central line insertion and line maintenance. And now I'm going to talk about the other major kind of infection, that is ventilator-associated pneumonia. But I have a problem making this diagnosis. I compare it to travel in the UK on a foggy day where you're going down the road, and before you see, maybe I see a ventilator-associated pneumonia, maybe I don't. But as you know, for those of you who work in the NICU, it's difficult to diagnose. Usually, no pathogen is identified because we don't do invasive suctioning of babies on the ventilator, like bronchoalveolar lavage. The choice of antibiotics is a guess, and we have a limited ability to monitor response to treatment. We just wait for the baby's respiratory distress to improve. And just when you think you've made the diagnosis of VAP, it disappears from sight, and you say, did I really make that diagnosis, or really was there a ventilator-associated pneumonia? So these are data from the US and from the International Nosocomial Infection Control Consortium, or INIC, shown in the parentheses. And the numbers are much higher, and they don't go down, which I worry about as a reflection of hand hygiene. And the numbers are much lower in the US and do go down. But I think we underdiagnose ventilator-associated pneumonia in the United States. And by the way, all these numbers you see here are cases per 1,000 ventilator days in both databases. So ventilator-associated pneumonia is difficult to diagnose, especially in our babies who have developing BPD or actually have BPD. We look for evidence of respiratory decompensation with new and persistent infiltrates. And that's important because sometimes we see an infiltrate that goes away the next day, and that's obviously not a VAP. The babies are mechanically ventilated for the most part, and the changes in respiratory status should not be explained by other events like atelectasis. And clinically, we suspect ventilator-associated pneumonia when there's a change in the characteristics of secretions accompanied by new and persistent infiltrates on the chest X-ray. So this is what the National Healthcare Safety Network and the CDC say are the criteria you must meet to diagnose ventilator-associated pneumonia. 48 hours of mechanical ventilation accompanied by new, and again, very important, persistent radiographic infiltrates. For them, non-invasive ventilation does not qualify, although we know babies on non-invasive ventilation can get a pneumonia. And then the other characteristics: worsening gas exchange, signs of sepsis, temperature instability, leukopenia, a change in the secretions commonly seen but may reflect a tracheitis, apnea, wheezing, Rales, rhonchi, bradycardia, or tachycardia. Why is the endotracheal tube so important? The endotracheal tube impairs ciliary action, obviously prevents coughing in the baby, and provides a protective milieu for high density bacterial colonization by forming a microfilm. And the bacteria get embedded in that microfilm and does not allow antibiotics to get to that site and kill them. These are the risk factors for ventilator-associated pneumonia from a meta-analysis published a few years ago. These were 8 studies. And the risk factors were obviously length of stay in the NICU, that one's obvious. Reintubation, which probably causes aspiration. Enteral feedings, a risk factor. Mechanical ventilation, transfusions, tinier babies, again, a surrogate for sicker babies. Prematurity, and bronchopulmonary dysplasia. In an intubated baby, the presence of bacteria on gram stain or culture or PCR from the endotracheal tube just represents colonization rather than infection. And the correlation between culture results from an endotracheal specimen and those obtained from the lung or pleural cavity of blood is very poor. There are some things on an aspiration from the endotracheal tube which can be helpful. For example, if you see an abundance of polymorpholeucophylleucocytes, neutrophils, or a significant increase prior gram stain, that's supportive evidence. But again, tracheitis can have an abundance of neutrophils. The presence of a single organism from culture consistent with the gram stain increases the likelihood of causality. So what's the pathogenesis of VAP in babies? Most organisms contaminating the trachea or lungs originate in the oropharynx. Therefore, in neonates, silent aspiration is a very common pathogenesis of VAP. Organisms can be present in the trachea prior to intubation or introduced during the procedure itself or afterwards from contaminated oral or gastric secretions. Mechanical ventilation leads to positive selection of these organisms, followed by tracheal colonization and then population expansion to lower airways. And that biofilm I spoke about a few minutes ago helps to keep those bacteria adhere to the endotracheal tube, and it causes bacterial population expansion. This is from a review article published by Garland a few years ago, which says that the lungs become contaminated from the ventilator tubing or from the provider's hands, that then the trachea gets colonized, biofilm is formed, and that biofilm helps to promote bacterial expansion and finally pneumonia in the newborn infant. In neonates, but not in adults, most bacteria infections of the lower respiratory tract are believed to result from microaspiration. There have been many studies in which dye has been placed in the stomach of babies being ventilated, and if you do that, if you use a food coloring within about 30 minutes to an hour, that food coloring will be evident from the endotracheal tube. Others have measured pepsin in the secretions from the endotracheal tube, showing that pepsin concentrations go up in babies who are being mechanically ventilated, and pepsin, as you know, originates from the stomach. Most aspiration events in babies are not catastrophic. They're subclinical, so they're really micro aspiration events. There's one paper from Hana Ali from George Washington University that supine position intubated babies promotes more tracheal colonization than a side-lying position. And when I show you my bundle to prevent VAP, positioning the baby may be important. Babies who receive methylxanthines and BPD are at increased risk of this subclinical aspiration. So how do you treat ventilator-associated pneumonia? In more than half the cases, the etiology is polymicrobial. When VAP is suspected, you start broad-spectrum antibiotics immediately. You don't wait to see how the baby's going to do. If the blood culture is positive, then it's easy, but in most babies, the blood culture is not positive. The most common pathogens are Pseudomonas aeruginosa and Staphylococcus aureus, but other gram-negatives can cause VAP. Etiology of VAP and sensitivity to the microorganism is going to vary from NICU to NICU. Empiric therapy always should cover at least those two pathogens, Staphylococcus aureus and Pseudomonas aeruginosa. There have been guidelines published from the American Thoracic Society in the US and the Infectious Disease Society of America looking at treatment of VAP when there's a likelihood of one or more drug-resistant organisms. I'm not going to read you everything in the second paragraph here, but there's using a lot of very strong antibiotics, broad-spectrum antibiotics. In neonates, I think you have a choice. If the baby's very sick and you have had any vancomycin-resistant, oxacillin-resistant organisms in your NICU, I would use vancomycin and gentamicin. If you do not have MRSA, methicillin-resistant staphylococcus, then I might use oxacillin and gentamicin as my initial empiric therapy. There's one organism which we've seen one case of in our NICU. That's Acinetobacter baumannii. That's resistant to most antibiotics and does require colistin. So here's my treatment recommendations about the staphylococcal coverage. People have argued back and forth whether linezolid or vancomycin are better. They're probably equivalent. Some experts recommend doing tracheal cultures 24 to 48 hours after starting empiric therapy. We do not do that routinely. The clinical response to any antibiotic therapy has to be closely monitored, and we treat most babies with what we suspect is VAP for 7 to 14 days. And now let me talk about prevention bundles. These have had a lot of benefit in adult ICUs. Most prevention bundles are suitable for NICUs, excluding the use of cuffed endotracheal tubes. And by the way, the use of cuffed endotracheal tubes is probably why the pathogenesis of VAP in adults is rarely microaspiration. But in the NICU, where we use non-cuffed endotracheal tubes, that probably has a lot to do with the pathogenesis of ventilator-associated pneumonia. Here's the VAP bundle. Meticulous hand hygiene after touching the infant and the infant's environment and respiratory equipment. Wear gloves when you come in contact with secretions or the oropharynx. This makes sense. Use a sterilized endotracheal tube for each intubation attempt. Have at least 2 care providers there for each endotracheal tube positioning or retaping. Clear secretions from the oropharynx before the endotracheal tube is manipulated. The infant is repositioned before extubation or reintubation. Inline closed suction techniques, while efficacious in adults, have not been shown to reduce morbidity or mortality. There's a large randomized study in babies showing no benefit to inline suctioning in terms of infectious or non-infectious complications. Prevent gastric distension and avoid it whenever possible. Keep the head of the baby elevated 15 to 30 degrees. Use left lateral positioning as tolerated after a feeding. Oral care, painting the baby's mouth with breast milk, a lot of places do it, or sterile water. It is not evidence-based. If you look at the national data, where the incidence of CLABSI has come way down nationally, as shown in the blue line here, the incidence of VAP in the NICU, not changed hardly at all. In fact, not changed at all. There's this recent study published in 2019 from Children's Hospital of Minnesota. They call it the ZAP-VAP study, ZAP meaning getting rid of ventilator-associated pneumonia. This is the bundle that they used. A lot of the things we have gone over as part of a potential bundle, but using it in this study from one time period to another, they're able to show a substantial and significant decrease in ventilator-associated pneumonia. And now I'd like to end by speaking about the diagnosis of any late onset infections. When you have a suspected late onset infection, you get a blood culture, a urine culture. Many times if the baby's quite ill, you get a CSF culture, white count, differential count. Some people measure acute phase reactant, CRP, or procalcitonin. This is sort of routine. What is not routine is the use of cytokines. And the one cytokine which has been measured in late onset sepsis has been interleukin-6. This is from a study published now more than 15 years ago, showing that in babies with proven sepsis, IL-6 concentrations go way up, but by 48 hours, they're back down to normal. In babies with a clinical suspicion, but now not proven infection, levels go up a little bit, then come down very quickly, and the controls, they remain at a control level. But IL-6 is not a routine measurement for most NICUs. How do you detect which babies are having cytokinemia? This is a very important study by Kuster and Georg Simbrunner from Munich, in which they measured a bunch of cytokines sequentially before and after the time babies developed an infection. So in the lower graph over here in orange, you see CRP, and it starts to go up maybe one day before infection, but then goes higher after the infection has occurred. But you look at the other two, the red is interleukin-1 receptor antagonist, and the blue dotted line is IL-6. Those cytokines are increasing a couple of days before infection. So they're earlier markers of a late onset infection. And that brings up the topic of predictive monitoring. We use these vital signs all the time in our NICU: heart rate, respiratory rate, saturation, and blood pressure. And they're very nonspecific. And when we use them in the NICU, they're very late markers of cardiorespiratory or cardiopulmonary compromise. When a baby has a bradycardic episode, we intervene and try to correct it. We don't look at the significance in the long term. But there's growing interest in analyzing the waveforms and the correlations between waveforms. And people have called that predictive monitoring as a way of predicting a serious ongoing event. There's constant crosstalk between organs of the body. Some of it's anatomic, some of it's neural, and some of it's endocrine. In healthy individuals, in healthy babies or healthy adults, these complex interactions result in variability of heart rate, breathing, and blood pressure, oxygen saturation, and temperature. Looking at it from the top, from 1,000 feet, the organ interaction looks highly chaotic. It's hard to see any relationship between those variables. But during a disease process in which there's stress, like sepsis, communication between organs and variability in organ system readout decreases. They call this, or statisticians call this, decomplexification. It represents an opportunity for early detection of a catastrophic event. So, for example, if there's an episode of sepsis, signals are sent back to the brain, and in the brain, through the sympathetic and parasympathetic nervous system, has effect on the heart. Now, there's a way of measuring that effect on the heart, and that's by use of the HERA score. The HERA score, the HERA device, is a commercially available device. I know it's present in Europe and the United States, which measures the heart rate characteristic index, or HRC index. What are the components of the HERA score? It looks at standard deviation of heart rate variability, sample entropy, it's the irregularity of heart rate, and sample asymmetry, it detects decelerations. Now, the decelerations it detects are very brief decelerations, not the kind of decelerations that we detect commonly in the NICU. And when the heart rate characteristic index goes up, or the HERA score goes up, that baby's at increased risk for a catastrophic event. Here's one of the devices available. This is a healthy baby, 5 days for a 5-day period. And you can see here the heart rate shows some acceleration, and then it goes back down to normal. The HERA score is very low. And here's a baby in which the HERA score goes up dramatically. And what you never detect in the NICU are these very brief decelerations, but they can be detected by using the algorithm of the HERA score. And when you see this, it does not equate with sepsis, but does tell you that the baby is sick and needs your attention. What are the limitations of the HERA score? Infants with acute or chronic lung injury, secondary to hypoxemia, acidosis, or lung inflammation, or brain injury can have normal heart rate characteristic index. A high or rising heart rate index is seen with repetitive apnea, and IVH can cause a persistent elevation of the heart rate characteristic score, or the HERA score, and that can last for a month. And if you do measure the HERA score, it's important to combine that with clinical estimation of sepsis. So in this study, you're looking at the probability of detecting sepsis. Over here, we have the heart rate characteristics going up, and here we have clinical score going up. The two in combination, and a normal heart rate characteristic index and a abnormal clinical score, are the best way to detect sepsis in a baby, and neither alone, either heart rate characteristic score or the clinical score, is as good. I'm going to leave you with a new score we're working on in collaboration with investigators at the University of Virginia, and that is a cross-correlation of heart rate and saturation, looking again for this outcome of decomplexification, where the correlation between heart rate and saturation goes up. Let me show you an example of that. Here we have heart rate, saturation, and actually respiratory pattern. This is in a baby who developed E. coli sepsis 9 hours prior to death. And you can see here that there's great correlation. Here's heart rate, here's the baby's saturation values, that the two curves could be almost superimposed on one another. In fact, the breathing pattern, which you're just beginning to investigate, follows the same pattern. And a study which we have published already is looking at this cross correlation between heart rate and saturation. When the cross correlation is low, there's a very low relative risk of late onset sepsis or NEC in the next 24 hours. And then when it goes up, the risk of sepsis or NEC goes up to 3.5. So it's a good marker. of a baby who is likely or may develop late onset sepsis or necrotized enterocolitis. So I think this is my final slide. Healthcare infections are an immense problem worldwide that increase morbidity, mortality, add trillions of dollars to the cost of NICU care. Almost all central line associated bloodstream infections can be prevented. And on the horizon are predictive algorithms. We're just beginning to scratch the surface with that using physiologic variables that can provide early warning signs, either for central line infections or ventilator-associated pneumonia. Thank you very much. And I apologize that I've spoken a little too long, but I'd be happy to answer any questions.
Oh, lovely. Thank you, Richard. That was amazing. I shall pass the floor on to John Smythe. He's the guy sitting next to me on the beach. He is our infection control lead, and he's burning with questions. But before we go on, Kurt from Newcastle asks if on the chat pane whether we could avoid changing ET tubes as a routine in our babies, because that's what the adults advise.
And I would recommend the same thing. We do not routinely change ET tubes, except when they're not delivering the ventilation that we want. So the answer is no, we do not routinely change our endotracheal tubes.
Lovely. Over to John.
Thank you for a really full, comprehensive talk, Richard, and very impressed with how your unit seems to have reduced your central line infection rate. We are trying the same. It's so hard to work out over periods of time which particular aspects contribute to the to improvements that you see. In terms of maintaining it, we've had a little bit more difficulty maintaining low levels, and we wondered about the yield from 2 blood cultures that seems to be more happening in the US, that you're taking 2 blood cultures at a time.
Yeah, we've always taken 2 blood cultures, but in the past we used a central line plus a peripheral vein blood culture until we became aware of this issue of line colonization that doesn't represent infection from a central line blood culture. Obviously, that's the ideal. You don't always have the opportunity to do that, especially in a tiny baby. So we try to draw 2 peripheral vein blood cultures. If not, we rely upon 1 peripheral vein blood culture and the baby's response to treatment. So if you're unsure, the baby looks ill, you draw your 1 culture and start antibiotics. But ideally you have 2, but it is not always possible, especially in the tinier babies.
Yeah, thank you. The biggest factors that we think, but obviously can't prove, is the starting of a daily central line ward round, as well as just getting a central line team together who are improving education, improving practice, particularly for line changes and not breaking the line. I don't know what you think. You don't know which factors, but which factors do you think may be more important than others?
So it's a good question. Hand hygiene above all. I think an important issue is how quickly we get our central lines. And I don't know what your practices are in Melbourne, but when a baby is receiving about 80 cc's per kilogram per day of enteral feeds, we try to remove the central line over a day. I don't know if you follow a similar practice, and avoiding central lines. I mean, I have lots of babies under 1,000 grams who we start enteral feeds, we give peripheral intravenous alimentation, and never put in a central line. So avoiding central lines, getting them out quickly. If you do put a central line in, we do have a dedicated team. We're really good at putting the central lines and always do it in a sterile fashion. For me, those are the biggest bang for the buck in terms of decreasing our risk. If you asked me 5 years ago, could we ever have 0 central line infections in a NICU, I would have laughed at you and said, it's impossible. But with that bundle that I showed you, again, in most months in a NICU, it's 0 or at most 1 infection. And 1 infection causes an uproar. And we try and figure out where did the lapse occur.
Yeah, that's amazing. And do you get any yield from where the lapse might have occurred? Do you get any
When our NICU gets extremely busy, I mean, our census is about 75 on an average day, and occasionally we'll go up to about 90 babies, and there's babies everywhere. The use of hand hygiene practices goes down. People get so busy, they run from one baby to the next without thinking to use hand hygiene before you go on and deal with the next infant's problem. So the acuity of our unit is a big problem. When it's down at 70 to 75, our hand hygiene compliance rate is usually about 95% because we monitor that on a regular basis.
Yeah, thank you. I've got a question from Prof. Victor Samuel, which is really asking about the role of fluconazole prophylaxis and probiotics to healthcare associated infections.
They're both great questions. Fluconazole has been shown to decrease the risk of fungal infections, fluconazole prophylaxis in babies less than 750 grams. In the big multi-center study, it did not improve outcomes. Because our risk of fungal infections is so low, we do not use fluconazole prophylaxis. If Candida or other fungal infections were more common, we probably would use fluconazole in babies who weigh less than 750 grams. And probiotics, I don't know what to say about that. I'm not a big fan of using probiotics in the NICU. They clearly, in bigger babies, decrease the risk of necrotizing enterocolitis. They've not been shown consistently to decrease late onset sepsis in babies. And in babies less than 1,000 grams, including studies from Australia, I'm not convinced that probiotics are any better than using breast milk to feed newborn infants. So we do not use probiotics routinely in our NICU, but we would consider fluconazole if our rate of fungal infections were higher.
Thank you. One last question is that we're using antibiotics for less time duration, shortening the duration of treatment and trying to use the early onset sepsis calculator, as well as using more PDHM, more breast milk. I think in Australia, we actually use oral nystatin prophylaxis and have done for many years. And we have a very low rate of systemic fungal infection also. You don't do that in the US,
No, I know there's a study or maybe even two studies which look at oral nystatin, not a lot of data, and it's something we routinely do not do.
Sure.
But I just want to mention that in terms of duration of treatment, I'm glad you're not treating babies with negative blood cultures for very long. And right now in our NICU, we treat for only 36 hours. And I think we're moving closer to 24 hours because most pathogens can be identified within 24 hours.
Okay, there's no more questions on the chat page, Richard. Just one query I had about your comment about silent aspiration. Lots of debate about that. Do you reduce the feed frequency, or nurse the babies hanging upside, or how do you prevent that?
So I don't know what to do about that. It's very common. The silent aspiration in most babies, it doesn't cause problems, but in other babies, it probably causes enough bacterial colonization of the airway to cause a pneumonia. Side positioning of the baby seems to be one of the recommended bubble part of the bundle, especially after a feeding. None of the individual interventions have been tested in that fashion. So it's really the bundle of interventions which are effective. It's just like CLABSIs. It's not one intervention, but it's the group of interventions which are effective. So I don't know how you prevent silent aspiration except by positioning of the baby after a feeding on the right side down.
And do you do long duration of feed intervals, like 3-hourly intervals, or do you tend more towards continuous feeding?
We do not use much continuous feeding except in babies that are feeding intolerant,
Okay,
and generally give intermittent bolus feedings every 3 hours.
3-hour feeds. Okay, yep. One last question from Dr. Arimitsu in Japan. All right, okay. So
Okay.
thank you for the great lecture. Are there any studies that show less ventilator-associated pneumonia in facilities with fewer eclampsies? I think hand hygiene is important in both cases. And
Yeah, I guess the question that, so I broke up a little bit, but I guess the question is this, is there a correlation between,
no,
I hear you.
between VAP, where is he? Is there a correlation between VAP and collapses?
The answer is not as far as I know. At Columbia, and I know you do in Melbourne, use a lot of non-invasive ventilation. So VAP is not a particularly important problem. We try to get the endotracheal tube out as quickly as possible. So we see very few babies that are ventilated for more than a few days, except for our cardiac population. But we still have collapses is still a risk. So if we're a source of data, we still see some collapses. We see very little VAP, and it's because we use mostly non-invasive ventilation for our newborn babies. But I don't know of any single study which has compared the incidences of those two problems in the NICU. I just can't answer that question.
Okay, brilliant. Thank you. He says thank you. All right, that's beautiful. Thank you, Richard. We've run out of time. So the take-home message is take out your central lines quick, nurse the baby right side down, right side down, head up, and do your rounds of the lines.
Get the lines out. Exactly.
Get those lines out at 80 mils per kilo. We're a bit scared about that, but yeah, we can try. John will crack his whip. Oh, one last question from Sam before you run away.
Sure.
Sorry, I didn't see that, Sam. He said, with neonates with prolonged neonatal jaundice, it's been recommended to exclude UTI. What investigations would you suggest?
So I agree with prolonged neonatal jaundice, since there's a correlation between urinary tract infection and unconjugated hyperbilirubinemia. I think it's worth looking for a urinary tract infection.
I guess what Sam is saying is, would you do a suprapubic taps or catheters, or what else would you do?
We do very few suprapubic taps. When I was a resident, we did lots of suprapubic taps. I do very few. We either do catheterization or try to clean the perineum and collect it in a bag.
Dr. Sam, does that answer your question?
Yeah, but many healthy babies with breast milk, they also have jaundice. Otherwise, totally healthy. Should we have to put the catheter?
No, if a baby is healthy and eating and behaving normally, I would assume that the jaundice is probably due to some other etiology and not a urinary tract infection.
When we do the urine microscopy, there are 150 WBCs. Babies well.
But that's a lot of white blood cells. If I saw that many white cells, I would culture the urine.
Thank you. Yeah.
Okay, so if there are no more questions, we're run out of time. So Richard, good luck with your elections. Hopefully,
thank you very much.
Either red or blue or whatever color you want.
We're blue.
Okay. All right. I think so is the rest of the world. Cross fingers. All the best. Okay. Stay safe. I'll be in contact. Thank you.
Thanks, Julie.
Thank you
Stay
so much.
well.
Bye, everyone. Bye.